a great day to get started with one of the most awaited webinars on shared medical appointments, or in other words, group consultations or group visits. So it's my pleasure to introduce our speaker today, Professor John Stevens. John is a friend, a colleague, truly a trailblazer in lifestyle medicine, especially in establishing the Australasian Society of Lifestyle Medicine, SLM, as a co-founder, and being a pioneer, popularizing the idea of shared medical appointments in Australia, or as we call it, group consultations. So with 40 years of experience spanning health practice, teaching, and research, Professor Stevens has dedicated his career to finding ways to help people manage and reverse chronic non-communicable diseases and age well through lifestyle interventions. So as you have already seen and read on our webinar advertising materials, he's a highly qualified health professional. He has trained over 2,000 professionals in shared medical appointment facilitation, and is passionate about using this model to empower communities, including Australia's First Nations people. So currently he leads the Master of Lifestyle Medicine program at Southern Cross University in Australia. We are thrilled to have him here to share his experience, expertise on group consultations with us. And welcome, Professor Stevens. Over to you.
Thank you, Sam. It's good to see you again. Sam and I first met a couple of years ago at the British Society of Lifestyle Medicine, and when things were just getting going. So it's great that we've been able to keep it going. So thank you very much for the invitation, and I hope I have something to offer for you today. I come from I'll start by sharing my slides. If I can find them again. Sam, where have I done with them? There we go. And Sam. And I'll just send it to view. There we go. So Sam, are we seeing slides?
Yes, it's perfect. Everything is great
Okay.
condition. Can hear you and
Yeah.
can see you.
Thanks, folks. I'm very happy to take questions as we go through, because I'm not quite sure where everyone's at in terms of understanding shared medical appointments or group consultations or group visits. So don't hesitate to drop a question in. Sam, are you going to be monitoring questions as we go, in case people put them in chat?
Yeah, I will do that. Thank you.
Thank you. All right. Today we're going to talk about the need for a new approach in primary care, given the rise of non-communicable diseases. We're going to look at a description of shared medical appointments. If you've not heard of them before, I'll do a brief description. But what hopefully you'll get out of this is that if you hear one description, you haven't heard them all. It's such a flexible way of delivering healthcare that it's quite amazing how people are using them in very, very different ways. We'll look at the concept of a program shared medical appointment too, and some of the issues about getting started and the barriers to commencing the use of them. I want to acknowledge that from my hometown in Australia, we acknowledge the First Nations people here, and my tribal group here is the Bundjalung Nation of Australia. I'm not Indigenous myself, but certainly doing what we can to restore health and well-being to our First Nations people. There's a story about me. These slides will be available to you. So some of these slides I have in here so you can read or catch up later. And I won't necessarily dwell too long on them in this presentation. And Sam or Morphy, if you would give me a bit of a wave when I've got about 10 minutes to go, 5 minutes to go, would be good.
Yeah, I can do that for you.
Thank you very much. So Sam said, I've been really lucky to have been an academic in the health sciences since about 1990. And I moved into the idea of aging well in the 2005s. And then we found the nation of lifestyle medicine around about then too, through my colleague, Dr. Gary Egger, some of you might have heard of. From there, we founded the Australasian Society of Lifestyle Medicine, and I'll tell you a little bit more about that story as we go. And I do run as a declaration, letting you know, I do run a course, a Master's in Lifestyle Medicine at a university called Southern Cross in Australia. So I come from Australia, and I live on this part of Australia, north coast of what we call the state of New South Wales. And I live, some of you might have heard of the Gold Coast, and I live in this place called Mullumbimby, which is near a town called Byron Bay, which is also very famous. And thanks to the world of internet and being able to do Zooms, etc., I'm able to live here. I used to live in Sydney, a very busy city, and I rejoiced at the fact of being able to come to live here and take my family with me to live in this beautiful environment, which is close to beaches and mountains, and very lucky to be here. Good for my lifestyle. The Australasian Society, Dr. Hung Nguyen is our current president. Some of you might have met or heard of Dr. Gary Egger and Andrew Binns in the past, and previous president, Dr. Caroline West, currently in Sri Lanka somewhere at the moment. So our version in Australia of lifestyle medicine has evolved as it has across the world. I'll just go back a bit. As you know, there's a World Lifestyle Medicine Organization, and there's also the International Board of Lifestyle Medicine. Some of you might have already done the exams for the International Board for certification. And some of you might know that the World Lifestyle Medicine Organization is also a growing new institution, kind of like the UN, if you like, of lifestyle medicine. We're very lucky to have that, as well as the accreditation board from the International Board. So we're well set up.
Very important time. And according to this,
so we're well set up, and for lots of good governance around the world. We've gone from 2006, when the Americans first got their first board together, and Australia 2008 officially. We've gone from those two organisations to, I think we now have 55 different organisations around the world who have a lifestyle medicine organisation like yourselves. And so these are our guys. And whilst there's lots of variations and differences between lifestyle medicine organisations, we tend to all coalesce around these 6 pillars of lifestyle medicine: nutrition, exercise, tobacco and or substance abuse, stress management, sleep, and connection or healthy relationships, variations of these things. And our work, our clinical work and our research sort of focuses on how to use these to improve our practice. I like to show this slide to sort of show the complexity of what it is we do, because we work at very many different levels. So we call this the hierarchy of disease causality, and I could run a whole semester on this slide alone, because it says so much to us. We know of the diseases that are starting to dominate our landscape now. The non-communicable diseases, type 2 diabetes is ravenous around the world at the moment, and I see from the statistics in Sri Lanka that it's grown really rapidly in the last 10 years, and I've got a statistic we'll talk about later. So we see these diseases here, and we know the risk factors, and we are good at learning this knowledge and skills, and at how to either prevent them or manage them with lifestyle. That's our job. So, but we know it's more than that. It's more than, this is where we exist in our day-to-day work at the coalface, where we know that type 2 diabetes, for example, risk factors for that are things like obesity. But what's caused the obesity? Well, we can work back upstream so far. We know that obesity is because of inactivity or diet, mostly. They're the sort of things that are acting on it. Lots of variations of that, of course. So, but then we've got to ask ourselves, okay, so we can work on people's diet or their activity, and we can improve obesity to prevent or manage diabetes. But really, what's causing that? What is causing the diet to be inadequate or the inactivity to be the way it is? If we work upstream, we could see that it's other factors that for most of us in our clinical life, these are starting to get out of our control as individuals working with patients. It's about their stress, it's about their poverty, it's about other things, about their occupations, about their relationships at home. They've got a stressful family life, which makes them eat poorly and become inactive, which leads to this obesity, which leads to diabetes. There's a whole lot going on up here, which takes a lot more time than a short consultation to deal with. And in fact, a lot of these upstream or midstream causes, if you like, or determinants of ill health are actually the result of things way upstream that are at the policy level or the environmental level. And as individuals, we really don't have a lot of control over this or power over this. And it's things like the political environment or the poverty or the socioeconomic status of people or cultural issues that are going on that cause stress or anxiety and depression or make people redundant in their jobs or put pressure on relationships and produce inequality. And all these things lead downstream to become type 2 diabetes. So this is why I love lifestyle medicine and why I love the organizations that we have, is because we are becoming very good not only at developing these skills and knowledge to deal with this area here, but as a group, as a bunch of 55 different organizations with tens of thousands of members growing with the movement in lifestyle medicine, we are starting to put pressure on up here to say, hey, you know, if you want to stop the diabetes revolution going on down here, we're going to have to fix things up here with equity or better pay for people or changing the environment with less sugar in it. Or there's ways we can operate together as a loud body. So I think lifestyle medicine is so powerful because we do this. We do the skills at the whole face, but now we are talking about being influential at this top end too, so we can make bigger improvements to people's health downstream. In Australia, just to give you a little bit of an indicator, we have it's quite a large country, 7 million square kilometers, and I think compared to Sri Lanka, which I think is about 65,000 square kilometers, I think we have about the same population. So, but you can see where the Australian population is spread. It's all around the coast, very little in the middle because it's desert and very arid, and it's very hard to live out here, especially with climate change. The temperatures and the environments are becoming harsher and harsher places to live. So we are retreating more and more to the coast, which brings with it its own issues. We probably, like Sri Lanka, will be very, very similar in that 1 in 2 Australians have a chronic disease. Most of our diseases are lifestyle related. Our top leading causes of death, illness and disability are cardiovascular disease, cancer and diabetes. About a third of our deaths in Australia could be prevented or lengthened out. And despite what we know about prevention, only about 1.5% of our huge budget for health is spent on it. So inactivity, the overweight and obesity, inadequate food and vegetable consumption, these are the 3 leading causes of lifestyle determinants that are leading Australians to high rates of chronic disease. 63% of Australians are overweight or obese. 95% of Australians do not get the right nutrition, which is hard to believe in a country as wealthy as ours. And it's quite an alarming statistic for us. And 56% are inactive and don't get enough of the daily movement. I did hype upon this statistic last year that there's been a sudden rise in diabetes prevalence rates in Sri Lanka. So at some point, some of these factors are similar in Australia as they are to to Sri Lanka in causing the rise of metabolic disorders like type 2 diabetes. And it's basically the same stuff. It's lifestyle, the way we are living our lifestyles now. But as clinicians, how are we going to deal with this rise in chronic disease and its prevention and its management? And we know that in the conventional one-on-one consultation, that is very difficult. Yeah, I'm assuming in Sri Lanka that the consultation is very similar to that in Australia, that it's a doctor-led. The patient has a short consultation, maybe 5 or 10 minutes. And in that time, this worked well for non-communicable disease, for infectious diseases, and it works well for small injuries and referral, but it doesn't work well for preventing and managing chronic disease like type 2 diabetes. We need much more time and much more resource than can be provided by one doctor and one patient in a very short consultation. A lot of people around the world who know a lot already about lifestyle medicine and better food and better movement, effects of stress and sleep, etc., and connection, have a lot of knowledge and skill already, but cannot find the way to practice it because of this convention of having this short consultation with patients, which is the dominant way of doing a consultation. And it's worked well in the past, but it's not working well now. It's not fit for practice anymore. In Australia, about 80% of all GP consultations now are due to a chronic disease of some sort, a lifestyle-related chronic disease. And so the short consultation is no longer being seen as adequate to deal with this as a way, as much more time is required and much more resources required to change behavior, to educate patients, to get them looking after themselves better. So this is where shared medical appointments becomes such a useful tool. In Australia, it's reasonably new as well. My colleagues Gary Egger and myself have been working on it for 10 years, but really we've been training clinicians in the last 4 or 5 years. And as Sam said, we've trained over 2,000 clinicians in how to undertake shared medical appointments. We've probably set up a couple of hundred, or maybe 300 or 400 medical practices, and we've worked with government agencies to start growing this. And we've just hit this critical point where people are starting to sort of take notice of it and thinking, wow, this is actually working, which is fabulous. You might hear shared medical appointments called all these other names. So in the literature, it's known as group medical visits, group medical appointments, group consultations. In Australian Aboriginal culture, it's called medical yarn-up. And you can let it be called whatever you like. But what we like to achieve in a shared medical is this: an individual medical consultation that's carried out with a number of patients watching on, and it's led with the skilled facilitator and the provider, GP in this case. With the other patients have similar concerns in the listening and contributing. So that's kind of like the definition of it, if you like. And so what we have, instead of a one-on-one situation, one doctor, one patient, we have maybe 8 to 15 patients. And we're not going to do 10 minutes, we're going to do about 90 minutes. And we have a small team of that slide didn't come on very well. We have a small team of a doctor and a shared medical appointment facilitator who we train to do this job. And over a period of about 90 minutes, we're going to have individual consultations with each of these 8 to 15 patients, but with everybody else listening. And we're going to take our time. And the consultation will be the same as if the person has come into the service wanting a one-on-one consultation, but they are now going to be having that consultation in front of others. And this is by choice, okay? We don't force people to do this. We invite people to do it. We explain it to them. We sign confidentiality agreements so they don't talk about other patients' problems out of the group. But often what we find is once that group gets going, there's no problems with this because they respect each other so much when they get into this situation. So it looks a bit like this. This is one slide which can tell you a little bit about this. So this was a group of patients that have type 2 diabetes and have for a very long time and still didn't understand their diabetes at all. The doctor was extraordinarily frustrated by seeing his patients again and again in his short consultations, not being able to make any headway with these patients. He's invited them to this group consulting, and here they are gathering in the practice, as you can see in the group. There's a whole process by which we undertake this shared medical appointment, and we train people to this, and we can do this training with you if you like, if this is of interest. This whiteboard's of interest because we use it as a bit of a prop to put names up and questions that people might like to ask. Sometimes we put results up if people want to compare and contrast, only with their permission, of course. The patients are gathering like this. They know they're here for a consultation about their diabetes. It's all very well explained to them. You've got a facilitator here. That's me with my big nose sticking out there. And as the facilitator in the shared medical appointment, for some, really the main role is held by the facilitator. Facilitator, before the doctor has arrived, facilitator welcomes the patients in, explains the scenario, keeps control of the group so that it's calm and relaxed, and that they don't go off on tangents that you don't want them to. I would, as I welcome these people in, I get a sense of who's very talkative. This guy's talkative. This guy doesn't want to say anything. This woman thinks she knows everything, so I'm going to be very careful about when I ask her for her information. This guy doesn't think he should be here. So you're using skills of facilitation to think, all right, when my doctor comes in, I'm going to start this by going to someone who's somewhere right in the middle, who is interesting, has something in common with the rest of these patients, but it's not going to dominate the meeting. So this fella here, for example, he had sore legs and vascular problems because of his diabetes, and so did just about everyone else in the room. So at some point I signal with the doctor, and the doctor comes in. He knows all these patients, but he's not seen them in this environment before, nor they him. And I suggest that he goes to Ben over here, and they begin their consultation. And Ben has the consultation with him as if he's in the room one-on-one with him. And over a period of time, he tells him about his feet. He reviews his notes, or he's done that before he's come in. And we talk about his feet and how his diabetes is affecting his feet. And suddenly everyone says, oh, me too. And this guy's kicked off his shoes and says, yeah, me too. And this guy's got really red legs. Yeah, my circulation's terrible too. Suddenly they understand that everyone in the room has circulation issues because of their diabetes. And it gives Hamish here, the doctor, the opportunity to explain that in some sort of detail, and why the medications and why the diets and the things that they're using are so important to prevent this happening. And so by the time he's finished the consultation with Hamish, someone else can rock in and ask, we'll go to somebody else who's got something similar going. And over a period of about 60 minutes, in this example, every one of these patients eventually gets a one-on-one consultation with the doctor. And the facilitator here will make sure everyone keeps to time and keeps on track to that. We're talking about diabetes, particularly in this particular consultation. When it's finished, after about an hour, well, this is the time that we decided Hamish could go, that he would only spend an hour here. And then I would spend another 15 minutes or so wrapping up some of the conversations about what had been said, or further explanations of what was meant by some of the things. More questions might have been asked. Meanwhile, the doctor, Hamish, is in his office writing his prescriptions, writing his referrals, and also finishing off his notes. And by the time these patients leave and go past the reception, they can pick up their prescriptions and referrals, etc. And other appointments could be made. So that's kind of how it looks in a room. We found during COVID that we could do this very, very well online, and this is a very powerful way of doing it. And we find this to be extremely efficient and effective because it saves people having to come to the practice, not in non-COVID times too. And it means people don't have to get dressed, they feel safe. We still do the same thing. We have a facilitator and a doctor, and the patients get to talk through their issue with everybody else listening and contributing. We want the other patients to sort of say, and you'll see this come up in a video I'm going to show very shortly, about how they've heard they have the same problem, etc. Here's an example of one done under a house. These are First Nations Australians who didn't want to meet in a clinical setting. They part of their cultural stuff with Australian Aboriginal folk is that often they don't want to be in clinics. So we meet under a house. There's the GP, there's a facilitator, and everyone here gets a one-on-one consultation with the GP under the house. So the location meant that some of these people had their very first consultation with a GP in this situation, because otherwise they would not never attended would never have gone to see a GP. This is a shared medical appointment with mothers with sick babies and babies that wouldn't settle after birth, and mothers who had possibly some postpartum issues. And so they were gathered, 6 mothers, 6 babies, and they would have a shared medical appointment about that. Every mother and baby would have their turn with the GP, with everyone else listening and learning and contributing their knowledge. Patients' knowledge in this is really essential, because they often know more about the day-to-day dealings with these issues than us as clinicians, because we're not in their world necessarily all the time. This is women who were pre-diabetic, who were overweight, and they were doing shared medical appointments. They were making no headway doing one-on-one consultations with their doctor in losing their weight. They gathered together in a shared medical appointment, what we call a program shared medical appointment, a program where we dropped in a weight management program and into the shared medical space. And over a period of 12 weeks, these women lost enormous amounts of weight, supporting each other. So they would come, there's the GP there, and over in the corner is a facilitator, and each one of these women would have a consultation with the GP about their issues to do with their weight or their pre-diabetes, their medication, their diets, etc. And over a period of about 90 minutes, all these women have an amazing interaction with each other and the GP. Another example of people who didn't want to be in the clinic to do this, the GP is working with all these women, again, on diabetes. We even bought some good nutritious food to sort of help it along. And you can see that the versatility of this is that every one of these women will get a one-on-one consultation with this GP about their diabetes. And they're relaxed, they're comfortable in this scenario. And there's a whole lot more there. We're doing a lot of work in the Northern Territory of New South Wales with remote and very impoverished communities where this method of the shared medical appointment is really well accepted in this scenario.
Shared medical appointments.
I'd like to show you a quick video. I'm not sure how we're going for time. Yep, we're going all right. I'll won't show you the whole video. I'll just show you some snippets of it, so you can get a real sense of how a clinic version of a shared medical appointment works, and I'll talk you through it as we go.
Shared medical appointments is a perfect place for people to learn from each other, as well as actually cut down on time for people trying to get in to see their doctor. The educational part of it, I think, where other patients are learning from each other, it's really interesting. I've never really seen it happen as well as it has. And And the added benefit is if people can get to see their doctor more readily and perhaps more frequently when needed, then it's sort of wins all round.
Hazel, do you have anything today that you'd like to see Dr. Jeffrey about?
Yes, all right.
Shared medical appointments is a perfect part of it. Is
Anything today that you'd like to see Dr. Jeffrey about?
Yes, all right. Every time I walk around the house, I go.
Sorry about that. So this is me as a facilitator. The GP is not with us at the moment. This is me welcoming, starting the process with this particular group of patients. And again, another group of patients who have had diabetes for a very long time, who never really understood their diabetes. So rather than the one-on-one consultation, this GP, you just saw there introducing this segment, tried for the first time shared medical appointments. This is their second visit, this particular group of people. And Gary here is writing names and some results on the board so we can talk about them as we go through. A lot of them still didn't understand what their blood sugar levels were when the numbers came up. They didn't really understand them. So we put them up and so we can discuss them. What you'll see here is me just sort of settling the room and understanding what's gonna happen before the doctor actually comes in. Oh bugger, sorry. My apologies.
shared medical appointment.
Experiences in the group probably from time to time.
One thing
I'd like to see Dr. Jeffrey about?
Yes, all right. Every time I walk around the house, I go walking shopping. I get base of my spine. I get, quite sore.
sugar's gone up.
Sugar's gone up a bit, has it? Okay. Well, maybe that's something we can talk about because that'd be something everyone experiences in the group probably from time to time.
One thing I should say is I got those ball foot things that you put underneath your
Yes.
ball, and it's made a difference. It's stopped a lot of tickling actually.
Great. So he recommended a foot.
They call it a football, I think.
A football.
But to me, football's rugby.
No, from England says.
I left that in because you can see the group actually bond very, very quickly and they support each other and they have a lot of fun when they're doing it. So these guys are having a joke about what football is in Australia. We have many different codes of football, as you might be aware, and not just soccer.
Man from England says that's not football.
I usually just do mine fasting blood sugar first.
So what you don't see here is now that the GP has entered the room, and as a facilitator, I'm sort of directing him as to who I think he should go to first, so we can get a nice meeting and group experience going.
Thing in the morning, and I'm quite happy just with that. I know what I'm doing.
Yep.
I can see what I'm doing. But if I were to do it after a meal, how long after the meal do I do it?
The recommended time is about 2 hours. So I guess the thing about blood sugar levels is there are standard times when people are advised to do them, but the main thing is as long as it's consistent. So that if you were to take your blood sugar within an hour after every meal, and that's when you did it, then you'd soon tell whether your body's able to respond to that sugar load. Or if you did your fasting blood sugars, it would tell you how your body is at keeping and maintaining, your level.
Which is probably a good segue into Reg, because his main issue this morning really is his sugar levels are up and down a bit at the moment.
So this is when the doctor and the facilitator work together as a bit of a team. The doctor's got a limited time in there. You've got to make the most of it so that everyone gets their one-on-one consultation with everyone else listening and learning from it. So the facilitator does helps sort of guide that process, if you like, and keeps the group, if you like, in some sort of order and relating back to the topic. We don't want patients sort of suddenly drifting off and going, oh, what about I've got this lump under my arm as well. That's important, and so we would make another appointment for them to see the doctor straight away, but it would not necessarily fit what we're trying to achieve here in this particular shared medical appointment.
Yeah. So
Just so I've gone up. I was up to 9, so
you want to tell us about strawberry juice?
and I knew I probably should 40 years ago, and occasionally you get laxity, and I've done a bit too much of that, and I've realised now I've got to get me hot.
The problem with diabetes, as you all know, is you get this small, tiny vessel disease, and it can affect the nerves. And the tiny little nerves that supply your feet can just go crazy.
So I showed this a little bit here because here is everyone has this issue as one of their issues with their diabetes, and Jeffrey's able to explain it in a really simple way to all of them at once. And yes, Sam. $10 minutes. Thank you.
Because they're not really getting, good blood supply, just like you're not getting strawberry jam and sultanas anymore.
Yeah.
So maybe, Rex, can we get your shoes off again? So what about if you close your eyes, and tell me, can you feel me touching you there?
Yeah, I can feel it.
Oh, sorry. Wow, how did that happen? So I'm just going to move. Sorry, I just cut that off. I was going to stop it there anyway, for now, just for this the sake of time. But you could see that it gave the GP the opportunity to demonstrate things in front of patients and made much more sense of it. These people walked out of this session saying that after 40 years, one guy had diabetes for 40 years, said, I've never understood it until this moment. And because he was not only not alone in his understanding of this, he was supported by all these other people. And the explanations were clear to him then. Look, the evidence for shared medical appointments or group visits is overwhelming now. There's at least 9,000 articles that we know of out there. None of them, there's not one that is negative about it doing harm. There's some that don't work, but on the majority they do. And they show that it improves effectiveness and efficiencies. It reduces waiting times and presentations to emergency hospitals as well. It reduces waiting times in medical practices. It improves patients' self-management competencies, which is really the goal of lifestyle medicine, that we get people looking after themselves.
The Sri Lankan Society.
Patient and provider satisfaction is extremely high. And we are learning that they are really powerful tools for managing type 2 diabetes and other metabolic issues. There's a few different types. And again, if we did some more training and more time, we could go into this. But basically, if you've seen one shared medical appointment, you've only seen one, because there's so many different ways of doing it. Homogeneous, what we call homogeneous shared medical appointment, is when people come with a similar disease like type 2 diabetes or Parkinson's or chronic pain or infections, or there's a whole range that we can use. We can get together on this. Program shared medical appointments is when we use the shared medical appointment process, but we drop in a program like weight loss or chronic pain management or stress, anxiety, or depression. That might run over a few different weeks. And this DIGMA, the drop-in group medical appointment, means people can come at a specific time and have any problem at all. It doesn't matter, just like a random waiting room would be. And we just put 7 or 8 to 12 patients in a room together, and it still works. We haven't done this much in Australia. I haven't tried this out, but I'm told by my American and British colleagues that this is a very effective way of improving access to it. Personally, these are ones I have been involved with. These are the sorts of conditions that we've been able to use in the homogeneous examples and in the program examples. And there's many, many more than this. I stopped adding to this list a few years ago. Quite varied now. The important thing is, and this, I guess this is the thing that separates it from the important point to walk away with here, is that it is definitely not a one-on-one consultation, right? It's a change from that, but it's not group education either. And this is where a lot of people who think they're doing shared medical appointments may be not getting it right. It's not group education. It is actually a one-on-one consultation with the patient, but just happens to be everyone else listening. You get a lot of group education out of it. That happens vicariously because of the way we go about this. And as a result, it's extremely powerful when you want people to, thank you, Sam, to do this. So the program type shared medical appointments, we developed them through our society for our services here in Australia. And we do things like quit smoking or weight loss, and we drop them into a shared medical appointment process. We recently just did a reversing of diabetes in Aboriginal women, a bit of research which was just fantastic. 40 women, 28 women finished this program over 8 weeks and reduced significantly the HbA1c. Something they couldn't do on their own in a one-on-one consultation, but in a shared medical appointment together as a group, they worked together on this, and were able to reduce significantly. And 7 of the 25 women actually reversed their diabetes completely in remission for 12 months. Things like that. This is a weight loss one where we ran 6 sessions over 12 weeks with these men, and they lost enormous amounts of weight because they were able to support each other in this environment. And there's a paper, you can find this paper within these slides if you want to follow that up. The patients tell us that they love this. We get 98% satisfaction rate, and we've done hundreds, if not thousands of these already now. Extra time with the doctor in a more relaxed place, having questions answered they may not have thought to ask themselves because other patients will do that. They get support and information from hearing from others' experiences. They know, oh, that medication did this, I'm mouth thirsty, oh, I did this for it. You know, they get so much input from the other patients that at a level that the clinicians can't access. They see the doctor in a different light, more relaxed. They get much more information about how to self-manage their issues. They get the doctor's full attention. They're not on a screen sort of working on their computer. They're actually engaged in them, especially because you've got the facilitator and possibly a documenter working in alongside you in the session. The providers say, this is the most wonderful thing I've ever done because I don't have to repeat the same thing again and again and again. You know, rather than having 12 patients come in and saying, this is how you treat your diabetes 12 times, you say it once. And it's just extraordinarily empowering as a clinician and not so soul-destroying about seeing the same thing again and again. Having a facilitator work with you is an extraordinarily good team approach that the GPs that we've interviewed love. They get greater productivity and efficiency when they set these up and do them well. You can see this. If you can see 12 patients or 10 patients in 1 hour, that's the same amount of patients you would have seen probably in 3 or 4 hours. You can get documentation support. The doctors come out saying, this is fun. This is exactly why I got into medicine, to do it this way. And I can use my knowledge about lifestyle medicine here in this space that I couldn't do in the one-on-one consultation. I can talk about nutrition. I can talk about exercise. I can talk about stress and connectivity and environment, etc. There are barriers, of course. This I made this sound so easy, and it never went wrong. Of course it did, but there are problems to be solved, and a lot of us have already done a lot of the hard work solving some of these problems. And it's just a matter of asking us, and we'd be more than happy to sort of help you understand some of these things and work problem solving with you. Change is difficult. You guys are pioneers. You're right here, right now, doing this because you want to change. You see the need for it, and good on you. But you know how difficult it is bringing a new idea into an established profession and a way of doing things. It's really hard. And somehow you need to convince wherever you're working, can't just go in alone. You've got to convince the whole of the organization that this is a good change to have. And we can do this. There's evidence now to show why we should be doing more of this if it's possible. There's obviously things to overcome, like privacy and cultural issues that might emerge at local levels. But all these things we've now been through hundreds, if not 1,000 or more shared medical appointments that have taught us how to problem solve these issues, and they're not insurmountable at all. In Australia, this method has meant that the income derived from doing this is at least enough to cover what we're doing. And in many cases, if they get the numbers up to a good level, then they can increase their income as well, quite legitimately. And so there's some really good outcomes from this. More importantly, the patients just get such a good outcome from it. And we've also got clinicians who just said, look, we were about to give up. We had enough of this job because it was just, we were making no difference to non-communicable diseases. And they've come away having done this saying, it's changed my career, I'm staying. And they're invested in this again now. Sam, I would imagine I'm getting close to time, so I better leave some for some questions. Folks, I've just gone so quick over such a big topic, just to sort of give you a bit of a taste test of what goes on here. And I'd be more than happy to provide more information or talk again with you if you want more detail or more case studies of how we've gone about this in different situations. But I'll leave that for you to work with Sam on. But for now, if there's any other questions, please.
Thank you very much, Prof. Thank you very much, Prof. Stevens. That was a great talk. And so far, we don't have any questions in the group chat, but there are some questions submitted by the participants before the webinar was started. I think some of these questions you have already addressed, but I'll just post it. If you feel free to pass on to the next one, maybe.
Sure.
First question is about how do you manage group dynamics to ensure all patients or clients are engaged, especially when there might be dominant personalities, educational differences, or varying levels of health literacy?
Yeah, good question, Sam. And that's why the art of a very good shared medical appointment is that you have a facilitator, a trained facilitator. They become the most critical part of this working for those reasons. So the facilitator will manage the group, manage the time, manage those difficult personalities, etc. They learn the skills. Part of the training is that they learn the skills about how to manage that and how to move people on or quieten them down or engage them better. The part of the success of shared medical appointment is that most times the group is invited in by the GP. So the GP, they already know the GP. The GP can be very careful about who he selects to come into the group. So if he knows he's got someone who's at war with another person or is someone with a radical idea that might upset the whole group, then they don't necessarily have to be invited. So the GP is, we know that if the GP invites patients directly, in their one-on-one consultations to come to a group, we get an 80% uptake rate. And if the nurses ask, they get about a 50% uptake rate. And if we have the reception asking people if they want to come to a group, then they get about 10% uptake. So in that, by the GP recruiting wisely, and we teach about how to go about that, and with a good facilitator, we in Australia, I can honestly say we haven't had. I've been personally involved in probably 400 or 500 different shared medical appointments. I've not had one problem with a patient being needed to be chucked out or be shut down with their noise.
Thank you. That's really helpful. Again, this is something that you touched on briefly. It's a long question. In brief, what are the most effective ways to train multidisciplinary teams, including doctors, nurses, and allied health professionals, to adopt group consultations, given that this is a new approach in Sri Lanka? And any insights as to how existing clinic assistants or clinic nurses could be trained to take up more clinical roles or other patient care related responsibilities during the consultations?
Yeah. This would come down to very much whatever resource you have available. as you can see, the facilitator role is very important, but and if there's a health background there, we have facilitators who themselves are GPs, allied health nurses, but we also have a lot of community people who become facilitators because there's not that resource around. There's not enough nurses or other people to help. So people from the community actually can become the facilitator, and they don't necessarily require, depending on the topic, but they don't necessarily require large amounts of clinical knowledge to be a good facilitator who can manage the group and the group dynamic. So to answer your question, there's no real rule about who should be a facilitator in that role. We have a training program through the Australasian Society that teaches people how to be a provider, how to be the facilitator, how to set it up in a practice. It's the hardest part is actually convincing your practice to come along and do this. Once you've got that sort of agreement and people are excited about it, then the rest is pretty easy. It's the training of it, as you can see, it's not that complicated once you get involved. And I imagine many of you are already doing groups of some sort somewhere at some level. The difference with this is that we make sure that everyone gets their consultation, their one-on-one consultation, if we can, to make it a group rather than group education. It becomes group shared medical appointment.
That's really helpful. Thank you. And we have more questions on the chat now. Let me pick one up. Has there been any studies on participants' socioeconomic and education status having an impact on the success of shared medical appointments?
That's a really good question, and it again comes back. So yes, there is evidence. There's lots of research articles, and by lots I've read probably, I guess, about 10 in the last 12 months that talk about the different cohort issues such as literacy, health literacy, socioeconomics, poverty, and other cultural issues as well. And again, those problems seem to be eliminated if you're careful with your recruitment. So it doesn't matter that people come in with very low literacy or very poor poverty. If we know the group that's coming in and we can work with that, it seems to work quite well. Some of the photos I showed before of the work we're doing in rural Australia, remote Australia, these are some of the poorest communities in the world, literally, unfortunately, I hate to say it, really, really poor communities in incredibly remote locations with very little literacy at all, yet gathered in a shared medical appointment in a place where they feel safe, with a provider that is good and knows them. It's really, really worked well, and it's changed the way in which we're doing health in these remote areas now.
Yeah, thank you very much. We have a few more questions. Well, I go to there's I think another question by Rukshani. What were the common issues faced in when conducting SMAs? I think you touched on some of the barriers. If there's anything else that you want to highlight, perhaps, or perhaps the most significant difficulty that you faced.
Yeah,
anything that you want to share.
Yeah, thanks, Sam. The question that comes up most often is confidentiality. How do you ensure confidentiality? And again, it comes back to that recruitment through, as the GP recruits or whoever does the recruiting, is conscious of any issues that are going on. And we do get people to sign a confidentiality agreement. Not that a piece of paper is ever going to stop someone from talking, but what we've found is the what's the word? The bond that the group forms is quite something. Really quickly, and they suddenly realize they're all doing the same thing. They've all got the same issue or a similar issue, and that they realize they're not alone. And here's someone who could support me. We've never had a single issue in the thousands of consultations we've had. We've never had a single issue of a breach of confidentiality. Just by the nature of the way it seems to unfold. we're careful. We've had plenty of situations where we've not brought people into a group because they're at war. And again, some of our experiences in remote Aboriginal communities is that some families, are feuding, and so obviously you don't bring them together in a group consultation, weed them out. Probably the reason a shared medical appointment doesn't work in a practice is because someone in the practice doesn't like the idea. Someone in their practice doesn't like change, and so the work needs to be done to sort of encourage people to give it a go or to think about it. And that's where sometimes it's good to bring in someone like me or Fraser, who you might have met last year, to talk to your practice, to say, hey, here's the evidence, it's all good. You give it a go, you can't go wrong, really. There's no harm. You really cannot do harm with this any more than what you're currently sort of setting up to do. So bringing people along for the ride is really, really important.
Right. Yeah, I think my line is a little bit unstable. We are almost about to finish our 1 hour, but before that, maybe can we take like 1 minute to answer this question very quickly, so that we have pretty much covered everything.
Yeah.
So how do you measure and demonstrate the impact? How do you measure and demonstrate the impact of group consultations on patient outcomes, and what indicators might be most relevant for a country like Sri Lanka, especially when we are focusing on cost effectiveness through the group consultations?
Look, that's a bigger question than I can answer in this time frame. But where we've been doing group consultations for a long time in America, UK, and Australia, we've developed lots of good tools to measure this stuff. And it's not hard. There's patient satisfaction work. There's plenty of examples of that. There's economic modeling. We have papers that show that the amount of money that is saved is huge, because it stops people going to acute hospitals, for things like diabetes. There's lots of tools that we can use and show you if we ever get a chance to do this again. The important part of this is that it remains evidence-based. It must remain evidence-based, and we do, and all our practitioners agree that that's what they do. They don't go off onto weird tangents and suddenly give advice about a Cardassian cucumber diet or something like that might be sort of radical in the fashion magazine. They stick to science, and as a result, we can measure those outcomes. And there's just lots of different ways of doing it depending on what it is you want to measure.
That's a great reminder. Yeah. I'm sorry, after you.
No, I know we're coming to an end, but I applaud you even listening to this, because it's, when you first hear it, it's such a radical idea. But then when it settles, you think, well, yeah, it's not that radical, really. We do a lot of things in groups already, and a lot of team talks and a lot of group education stuff. Why not? And all I can say to you is there's not a lot of harm to be done by trying this. The only harm is that if you don't do it well at the start, you might turn people off it, and so they might want to do it again. So, but if you give this a go, if you are clinicians who are looking for a change and a way of doing things differently, this is a really good and exciting way to do health.
Thank you. I think that's a great place to stop our conversation. And thank you very much, Prof. Stevens. Really appreciate your time and always accepting our invitation to be with us. Once again, a big thank you from all of us here at SLSLM, as well as all the participants today.
Sam, it's so good.
Really appreciate it. And we hope we can perhaps have a more detailed session. Yeah, sorry.
No, good. Sorry. Part of the problem of being on Zoom, isn't it? We can't sort of work out our body language. My apologies for jumping in on you. Then only that I'm so grateful for the opportunity to be able to talk about this with your lifestyle medicine clinicians. So thank you.